Hey everyone, my name is Destiny, and today I'll be showing you what it's like in the life of a psych COVID nurse. I know COVID is still going on, and a lot of you guys don't really know what all it brings about, but today, hopefully, you can kind of see what we do here at work. So right now I'm about to get report from day shift, and report is just basically me learning about the patients that I'll be caring for. Usually we have about like 10 or 11 patients at night. It's usually very boom, boom, boom. But tonight we actually only have 4 patients. So I'm so excited. And I just thought I would take this time to film so you guys can see what we do. And correction, let me just say we usually have 11 patients per nurse. So yeah, it's a good night if I only have to have 4 patients just to myself. I can actually give the care that I want to give, take extra time with them if I need to, and everything. So yeah, it's gonna be great. And actually, this unit that I'm on is an adult psychiatric unit. A lot of dual diagnoses like schizophrenia. I see that a lot. Drug use, um, and then bipolar, suicidal thoughts, things like that. Okay, so here's an example of the patient census chart that we have in our conference room. And it's specific to each patient, things we have to know about the patient when we're getting report from the nurses to make sure that we're all on the same page. For an example, room 1, this patient, this is the room that they're in. PL stands for the status of monitoring that we have to do. So RM stands for routine monitoring, which in a psych hospital, that'll be every 15 minutes. Patient 2 has PL1, and that means that they have a sitter with them at all times, and that's usually because they've been self-harming on our unit and they can't be trusted basically alone. And then PL2 is more so line of sight, meaning that we have to keep a closer watch on them than the routine monitoring, but it's not as severe as the PL1. All right, these are example patient initials, of course. Patient AB, that's the name, and they're under the care of Dr. Medicine. They are going to discharge on Valentine's Day so they can be with their boo thing. Their legal status is what we have to go by that keeps them as a patient. So VOL stands for voluntary, meaning that the patient is here at will, whereas involuntary means that the patient legally has to stay in the care of the hospital until the doctor determines that they're good to go and to be discharged. Vital signs on a COVID-psych unit, they have to be done every 4 hours. The good thing though about these patients is that they are asymptomatic, so we don't have to do like continuous monitoring like you would in the ER. And we also don't even have things like oxygen and things like that, so we really can't take patients that are really, really sick. And last but not least, this is what would be your additional information. So patient AB is a fall risk, and you have certain protocols in place to make sure that we don't let the patient fall. So we would place them closer to the nurse's station. Patient 2 has Hep C, so when we draw the lab work, we have to make sure that we're, being extra cautious. I mean, of course, anytime you draw labs, you should be, because you never know what a patient is carrying. Room 3 is pregnant, so that's a whole nother can of worms that you have to be aware of. And then room 4 is, both of these are under the care of Dr. Schizo. If you need anything done, that's the one you would have to contact. This patient is diabetic, so AccuCheck means that that's the the way that we test their blood sugar, and ACHS means at before meals and before hours of sleep, so 4 times a day. All right, I hope this was a good example of how we do our patient list. So after you get report from the nurses, you want to go in and log into your patient's chart, and you want to check their vital signs, check their allergies, check their basically all around, because you want to make sure that you don't miss anything. You want to check when they last got their as needed medication, so that you don't give a dose too quick in between. And you just want to, make sure you're on your P's and Q's, so that when it's time to give your medication, you'll be ready. So, yeah. Okay, so this is the med room. We use the medication system Omnicell, and what it is each medication is in each of these drawers. You have to type in your username and password, and then pull each of your medicine. So this is one of my example patients. This patient has a history of a kidney transplant. So this first medication actually has to help with the kidney transplant. The second medication is Elavil. That's a sleeping medication, and it helps with depression. The tacrolimus is also a kidney transplant medication. Trazodone is a common medication we use for sleep. And Ativan is a controlled substance that we use to help for anxiety. And then the last medication is metoprolol, and it's a blood pressure medication. So this is my computer on wheels, aka CAL. This is how I give out my medication. It's got my keyboard. This is where I store my medications and my extras, like my alcohol and stuff, just in case I give a shot. Of course, gotta have your Germ-X, pill cutter, Band-Aids. And then my cups are on the side, and my medicine cups right here, and then my cup for water. So during your medication administration, we have to do our daily assessment, and basically we have a series of questions that we ask the patients to make sure that they're going to be good to go home. So a lot of the times, a lot of psychotic patients, or just patients with increased anxiety and depression, is really due to a lack of sleep, and you don't realize how important sleep is until you stop getting it. So what we do is we ask them how they sleep at night. If they have trouble falling asleep for a while, we call that initial insomnia. And if they have trouble, if they go to sleep fine, but then they have trouble staying asleep, we call that middle insomnia. And so we have medication that we give, such as Trazodone or Seroquel or Remeron, that helps the patient sleep through the night. Next, we ask them about their appetite. If it's decreased or increased, that may be side effects of medication, or if it's decreased a lot, that may be a potential indication of an eating disorder, but more factors would have to be in place for that to even come up. Next, we ask them about their energy level, because some medications can be very draining to your body. So if you're sleeping too much, the doctor may need to know so that he can decrease your dosage. Of course, the main thing we want to know if a patient is suicidal, and or if they just don't have a desire to live, and that's self-explanatory. We also ask patients if they are feeling like they are homicidal or wanting to hurt anybody, because sometimes it goes ignored, and then things happen, and you just have to make sure that you're fully assessing your patient. We ask about hallucinations to everyone, even if they didn't come in for hallucinations. Again, it could be side effects of a medication, or not sleeping well, or even withdrawal symptoms from alcohol and things like that. The A is for auditory, the V is for visual. So the AVH stands for auditory visual hallucinations. We, of course, ask them if they're having any depression or anxiety, and we actually ask them to rate their depression or anxiety levels on a 0 to 10 scale, 0 being 9, 10 being the most ever. And that just kind of gives us a gauge of where we stand and how we're treating that. We have to ask about their bowel movements. Sometimes it goes ignored, and then next thing you know, patients are constipated. So we just ask them that just in case they need a stool softener. But on night shift, we don't really ask them that type of thing, because how are you going to sleep if you're trying to go to the bathroom every few minutes because you've taken a laxative? So we just ask just to make sure. And then, of course, pain. Everybody can be pretty irritable, not themselves when they're in pain. So we just have to ask them that. And, of course, we just generally ask how their day is going, because, and not even always their day, because something may have triggered them in the daytime. So we ask them how they're doing in the present moment, just to facilitate some type of conversation, but to help them, get some things off of their chest before they go to sleep and everything. So that's pretty much it with what we're assessing the patient when we do our medication. So I'm going to show how we put on our PPE, and of course I have to have my mask on at all times, so that's going to already be on. But next I have to put on a head wrap, a head thingy like this, and it really makes me look like a lunch lady, but it's okay. Next, I'm gonna put my gown on, like that, and it's super huge, but I can tie the back around like this and bring it around front. Also, I've already put my shoe covers on as well. So, and what else? So I have goggles and I have a face shield. Sometimes I go back and forth between these because sometimes the goggles kind of mess with my lashes. So I put the face shield on like this, and then I put my gloves on. So this is where we chart how we interacted with the patient and how the patient responded. And basically we chart, are they sad and gloomy, or are they cheerful, talkative, hyper? We call that manic. Are they angry or aggressive? Those type of things we chart for the doctor to look at and make that type of assessment on whether or not they need to stay or discharge. So I'm on my break right now, and basically it's not too much left to do. All I really have to do left is to recheck my vital signs and to do rounds on the patients every 15 minutes if one of the techs needs to take a break. And then give out morning meds and draw morning blood draws if there are any. So that'll pretty much wrap up the night and give report today's shift.